Free Market Foundation, and thank you very much to the media for attending today and everybody else. It's fantastic to see so many people here. I have the pleasure of introducing our speaker today, Dr. Anthea Jeffery. It's always a really great experience listening to Anthea. She has some really fantastic insights into various sectors of the economy and obviously in healthcare. So we're very pleased to have Dr. Anthea Jeffery here today. I'd also like to just provide some opening remarks on the subject matter today. I want to make it clear that the Free Market Foundation is in favour of universal healthcare, but I don't think it takes someone trained in the economics profession to understand that there's something seriously wrong with the idea of free healthcare for all. Because everybody knows there's no such thing as a free lunch, and if the government's going to spend in one area, it necessarily comes at the expense of somewhere else. So we believe it's neither necessary nor appropriate for the government to provide free healthcare for all, because as I said, doing so is not a particularly good use of scarce taxpayer resources. I think having taxpayers fund healthcare for the poor is one thing, but intruding onto those who can afford to pay for their own healthcare is something entirely different. So for many years, the Free Market Foundation has suggested that the government should adopt the same constitutional framework as it does for other constitutionally mandated objectives such as education and housing, and simply focus on financing healthcare for the poor instead of providing it for free for everybody. And more specifically, we believe in a voucher system which has been means tested, and I'm sure Anthea will elaborate on some of those things, and the race relations also have their ideas on how a voucher system and a means tested voucher system specifically will work. Finally, I think from our perspective, if the government views it as politically essential to have universal healthcare, then it can insist on a mandatory form of insurance, but that covers catastrophic health-related events, but otherwise leave people alone and let them decide for themselves where and how to spend their money. So finally, without much further ado, I'd like to introduce our speaker today, so please join me in welcoming Dr. Anthea Jeffery.
Hello everybody, and thank you for giving me the opportunity to speak today about the NHI, which I think is an extraordinarily important issue. And my brief is to talk about alternatives to it. But we need to begin with an understanding of the NHI, what it proposes to achieve, what its outcomes are likely to be. And so that is where I would like to start. So if we're going to understand the NHI, first we must see what its goals are. The aim is to pool all health funds so that the country can then provide universal access to quality and affordable health services for all South Africans. And these services will be free to all patients at the point of delivery. And they'll be implemented through an NHI fund into which all health monies will be placed and from which all health expenses will be met. So that's the essence of the idea, and the promise of affordable and quality healthcare that is free to all sounds enticing. However, the NHI idea is based on many flawed assumptions. To begin with, it's very often said that 16% of South Africans belong to medical schemes, so the remaining 84% must be dependent on public health care. But in fact, the usage statistics are quite different, as people from the Healthman Consultancy and others have put forward. So 37% of people in fact use private GPs, 29% use private hospitals, and 59% use private specialists, with many people who don't have medical scheme coverage paying for these services out of their own pockets because they prefer to do that rather than to rely on the faltering public health system with its often great inefficiencies and long waiting times. And it's often also said that the private sector is not doing its share. But in fact, of course, the private sector provides the great bulk of funding for healthcare, both, of course, in the private sector itself, but also through taxes to fund the public health system. There's another flawed assumption that the private sector prices are far too high and that this is the product of greed, of putting profits before people, of being a ravenous monster, as the health minister back in 2004 put it. But an analysis was done by a statistician a little while ago in 2012, and he said if you really compared like with like, bearing in mind the extent of subsidization for public hospitals, then private hospital costs were 1.1 times those of public ones in 2012, which is not a huge differential. And the main cost drivers in healthcare are, of course, increased utilization, the growing burden of disease from AIDS and other non-communicable diseases, the aging population, new medical technologies and medicines that are constantly being developed, increased labor costs, particularly nurses, because salaries have gone up so much in the public sector that the private sector has had to raise salaries too to keep pace. High administered prices, we all know what's happened to electricity, and generally high inflation as well now as the falling rand, which obviously makes it much more difficult to afford anything which has to be imported. Then there's also the very important matter that the government's own regulations also increase the cost of private healthcare. So we have restrictions on the establishment of new hospitals. You need the government's permission or the expansion of existing ones. We have a prohibition on hospitals employing doctors, which pushes up the costs for doctors who have to provide for their own consulting rooms, billing systems, and so on. We have a refusal to allow the private training of doctors, which contributes to the shortage of doctors, whereas if there were many more doctors all competing for the custom of patients, this would also help to bring down prices. Instead, the government prohibits private training, and the public university places are simply too limited. They've hardly expanded at all since the 1970s. Also relevant is the single exit price for medicines, which prohibits the giving of discounts for bulk orders in the private sector. So if a private hospital knows it needs a great deal of X and it would like to put in a bulk order and get a discount for it, it's barred from doing that by the single exit price mechanism. Then critically important are the prescribed minimum benefits, about 300 of them, and all medical schemes must provide coverage for all these PMBs, irrespective of what scheme their members are on, and then must also pay for treatment for the PMBs in full. So it's been reported that in 2015, the minimum cost of covering PMBs per person is 600 Rand a month. So that's the minimum that a medical scheme can charge. And that means that it's very difficult to provide a lower cost medical scheme. Initially, the PMBs were supposed to be treated in state facilities and public hospitals, but there was then such an increased burden on them that a complaint was raised, and in time the Council for Medical Schemes ruled that payment would be obligatory for private treatment as well. And the result has been a huge liability for medical schemes, and they have to keep putting up premiums so as to cover costs. And this is making medical scheme membership unaffordable for more and more people. The latest report, which has just come out, indicated that medical schemes had an operating loss of 1.2 billion last year. And this was very much the fact that, or at least rather said, partly the result of the fact of an increased usage of the PMB provisions and therefore an increased liability for the schemes. And the government will not in fact allow lower cost medical schemes, which are freed from the PMB obligation, which would extend coverage to 15 million more people. This was a proposal that was put forward by the Council for Medical Schemes last year. They were going to go for it from the 1st of January this year, but then after a meeting of the ANC, they decided they changed their minds rather inexplicably. And it was certainly rumored that this was because the ANC had put pressure on them, saying that a lower cost medical scheme will undermine the case for the NHI. Oops, what have I done? The government is now also seeking to ban medical insurance schemes, which are also a low-cost option. Many of these are combination schemes, which give you both hospital cover and cover for a certain amount of day-to-day care. Medicines Control and Council is also backed up with a whole number of applications. It takes a long time, sometimes up to 5 years, to give approval for generics. And part of the result of that is that generic use in South Africa is lower than it is in other countries such as the US and the UK. And then the other thing is that poor standards in the public sector, which are often also the product of regulation, are pushing people towards the private sector. If the public sector was functioning optimally, then people would of course be glad to use it. Instead, they feel under pressure to turn to the private sector and avoid the problems in the public one. The budget for public health care has in fact increased very substantially. It's gone up from 15.6 billion in 94-95 to 182.7 billion this year, which is an increase of 1,050%. And yet there are so many problems in the public health care sector that we get the feeling that we're not really getting bang for the buck. Dr. Aaron Botsaledi, the Minister of Health, has acknowledged that there is a management crisis in public hospitals. And why is that? It's largely because people have often been appointed for reasons of demographic representativity or political loyalty as part of the cadre deployment program. And the Development Bank of Southern Africa in 2011 reported that teachers, nurses, even clerks whose highest qualification is a matric are running the hospitals, and they lack the experience to be able to do a proper job. According to healthcare workers in Gauteng, the upshot has been very poor administrative and financial management, and this is then reflected in any number of problems in the sector, particularly late payment for essential supplies, which means that suppliers sometimes cut off. They simply can't carry on without being paid, and poor supply chain management. It recently emerged through the Stop the Stockouts project that perhaps 20% of the stockouts could be attributed to a lack of necessary ingredients and supplies, but 80% were because of logistical problems. That very often the necessary medicines were in the provincial depot, but they weren't being sent out to hospitals and clinics as required, and partly because the system of communication had just broken down. There are constant shortages of doctors and nurses, many of them driven away from the public sector by the poor working conditions. And there's also poor maintenance of hospitals. In the Free State, for example, doctors complained recently that because lifts at a particular hospital had broken down, patients in ICU couldn't just be put on a stretcher and carried down the stairs. So they couldn't be taken to theatres, and some of them died. So avoidable deaths from the lack of maintenance. Then there are also long treatment delays. In 2015, it was reported that in the Chris Hani Baragwanath Hospital had told a man who needed hip replacement surgery that he would need to wait 7 years for this to be provided. And according to the Gauteng MEC for Health last year, there are up to 66,000 people in Gauteng who need cataract surgery and on waiting lists, sometimes for up to 3 years. Then there was also a very disturbing report that was compiled by the South African Medical Research Council, which came out in 2015, which dealt with events in 2012 and 2013, and came to the conclusion that more than 82,400 babies had died for avoidable reasons in approximately 600 public facilities. And the report stressed that basic treatment guidelines had not been adhered, and hence this very high death toll, partly childbirth, partly because babies were starved of oxygen after their birth and they died. Other babies have been left badly brain damaged for the same reason, and so there are an increasing number of really harrowing cases coming before the courts where parents are claiming damages for negligence which has left their children severely impaired. By March 2015, the state's contingent liability for medical malpractice lawsuits stood at 25 billion rand, and I see today that the Gauteng provincial administration will have to pay out 1 billion rand this year in such claims. In 2012, a baseline audit of approximately 3,900 public facilities was conducted, and it found that most scored very badly on such essentials as cleanliness, staff attitudes, infection control, the availability of medicines, and so on. And the health minister himself described those outcomes as appalling. This led to the establishment of the Office of Health Standards Compliance, the OHSC, which started work in 2013 and has re-inspected 417 facilities, which it did in the 2014-15 financial year. And it found that 3% were compliant in full with the government's norms and standards, that 13% were conditionally compliant, so only if they could deal with the problems identified. The remaining 84% were non-compliant, of which 40% were critically non-compliant. So the indication is if the NHI were to be introduced tomorrow, unless there are radical improvements in the public health sector, only about 16% of public facilities would qualify for accreditation and participation in the NHI. Sorry, my mouth's getting very dry. I just need to have something to drink. Thank you. And part of the problem, too, is that the OHSC lacks enough inspectors to be able to go out and inspect all the private practices as well, and private hospitals that would also have to be certified for accreditation. So as the situation stands now, there's a real risk that 55 million South Africans would have to rely on 16% of public health sector facilities if the NHI came in right now. The NHI is a supposed solution because it will pool public and private spending in the one fund, the NHI fund, because it will draw in both public and private health facilities and health practitioners. It will also hold down costs, says the white paper, because there will be price controls on hospitals, on doctors, on all health practitioners, on medicines, on medical technologies, on consumables, on everything that is needed for healthcare. There will be a price, and it will be a price controlled by the state. And the state will also be empowered to decide what benefits should be made available, what treatment protocols should be applied by doctors, what diagnostic blood tests should be allowed, what medicines should be prescribed, what new medical health technologies should be approved, and so on. So there will be very comprehensive state controls on the entire healthcare system. And if we look at some of the problems with the NHI, well, first of all, there is still, despite the white paper, no clarity on what benefits the NHI will offer, which means it's very difficult to work out how much the NHI will cost. But the white paper does give a long list of the sorts of benefits that the NHI should include, from preventative, curative, rehabilitative, palliative, things like opticians, health, speech, HIV/AIDS, TB, reproductive health. It's a long list that the NHI seems to want to cover. The Minister has said that the NHI could cost up to 1 trillion. It all depends on how we design it and what benefits are included. The white paper has said it's not useful on trying to get to an exact figure regarding costs, and in fact it's the wrong approach to say what will the NHI cost. And the white paper, however, then goes on to estimate that total costs in 2025, when the NHI will be fully operative, will be 256 billion in real terms. But it doesn't really explain how it got to that figure. It assumes the economy will grow by 3.5% a year, so that this increasing health expenditure will still not be that much of GDP. It will end up at 6.2% of GDP as opposed to about 3.8% now. But is the economy going to grow at 3.5% a year? And it estimates that the revenue shortfall in 2025 will be 79 billion rand, which can be covered in various ways, by a 1% payroll tax, by a 1 percentage point increase in the marginal rate of personal income tax, by a 1 percentage point increase in the VAT rate from 14% to 15%. But of course there would be political problems with two of those options. So the other idea is that you would simply raise the marginal rate of personal income tax by 4%, from 41% to 45%, and this will cover the 79 billion shortfall. But the shortfall could be much bigger than that. Dr. Jonathan Bromberg, the CEO of Discovery Health, said in 2009 that if you were to provide the average package of benefits to all South Africans, that this would cost 497 billion rand, or 20% of GDP. And this, of course, was a figure provided a number of years ago. If you assume, which I'll come to later, that health costs have gone up by 45% in 5 years since then, we're talking at least 720 billion rand today. If we say we're going to cover just all the PMBs, the 300 conditions roughly, that would cost at the rate of 600 per person, roughly 400 billion rand. And what the Department of Health is saying in essence is that we can pool public spending, which is 183 billion this year, and private spending, which is 189 billion, which will give us 372 billion, which is not that short of the 400 billion figure. But of course it assumes that you will still be able to raise that 189 billion from the private sector for a system that will be very different from what they have now. Then the government also talks about pooling the money in the compensation fund and the road accident fund, saying this will contribute to the pool. But unfortunately, the compensation fund seems to have a liability of about 25 billion rand. There's something like 231,000 claims which have remained resolved for more than 10 years. So there's a big shortage in the compensation fund rather than a big pool of additional money. And the same with the road accident fund. Its recent annual report indicated that it had liabilities that it would have to fund at some point of 145 billion. Membership of the NHI will be compulsory. You may not want to use its benefits, but you must contribute to its costs. And private medical schemes will be confined to providing only complementary services. In other words, they can provide things which the NHI itself is not providing, but they can't provide anything which the NHI is providing. So that means that all that medical scheme covers will be able to cover, depending on what the benefits of the NHI are likely to be things like specialized dentistry or rare diseases such as hemophilia, uncontrolled bleeding. And because the pool of people wanting that cover will be so small, the costs will have to be very high. So probably most medical schemes will not survive. They simply won't be able to function in such circumstances. And private practitioners may then find themselves compelled to participate in the NHI. At the moment, much of their business comes to them through members who have medical scheme, people who have medical scheme membership. Then there's also the certificate need under the National Health Act of 2003. There's already provision in the statute, though these particular clauses haven't yet been brought into operation, saying that any health facility, any health practitioner must obtain a certificate of need from the Department of Health before he or she can open or continue with an existing practice. And the grant of certificates of need will depend on things like the geographical spread of doctors in the country, on the burden of disease in various parts of the country, and so on. And it may be that many doctors who want to practice in the metropolitan areas, for example, would battle to get certificates of need to do so. So between all of these factors, I think it's quite clear that the NHI will effectively put an end to private health care. And this seems to be an objective of the government for some time, because it has described, as I said, the private healthcare system as a ravening monster, and it does not want the commodification of healthcare through business, private sector being responsible in part for providing it. Part of the problems is that we have such a tiny tax base. 480,000 people pay 57% of income tax. And obviously these are people who earn more than 500,000 rand a year. They're among the most highly skilled people in the country. Their skills may be in demand in other parts of the country. So many of them might choose to immigrate, because having access to good health care is so vital to the middle class, and that would have major impact on the taxpayers. And most countries which have introduced universal health care actually have a much bigger tax base than South Africa, and they have much lower unemployment. Obviously, the two things go together. Money will also have to be found to pay for a huge new bureaucracy, which I'm going to describe in a moment. And the NHI will be a major additional liability on the government's budget. So therefore, it could in itself help to trigger a ratings downgrade. Ratings agencies have flagged the NHI as one of their concerns, knowing that it will be very expensive to introduce. So if we go ahead with it in these circumstances, with growth so low and revenue insufficient, this could help put us in the rating downgrade territory. If we look at the bureaucracy required, excuse me again. We start with the NHI fund, into which all money will be placed, out of which all expenses must be paid. And it's been estimated that we might need up to 160,000 officials to reimburse all the hospitals, clinics, doctors, other health practitioners who will have provided services to patients free at the point of delivery and now need to be reimbursed by the NHI fund. And if the compensation fund is any indication of the kind of efficiency we can expect, then there they have 231 claims which have not been dealt with over the past 10 years. How many claims submitted to the NHI fund will also be dealt with very slowly, with perhaps delays of at least 70 days or much more before payment is received. We might also need, and this is my speculation, another 160,000 to pay for all medicines, consumables, etc., because all medical equipment and other items, goods and services which are needed will also be paid for out of the NHI fund. And this fund will have 8 subunits which will have various functions. In essence, they'll decide on benefits, they'll determine prices for doctors, for all medicines and so on. They'll accredit doctors, they'll procure the supplies that are needed, they'll pay all providers from doctors to pharmaceutical companies, they'll monitor the performance of the entire system, and they'll guard against fraud. Well, it's nice to know that they're going to guard against fraud, but if you look at the details in the white paper, there really is simply a whole number of paper exercises which are envisaged, setting up more systems and controls and so on, but they don't really talk very much about holding people accountable or punishing them for corruption. And we know from Kenneth Brown that 40% of the government's 600 billion procurement budget is being lost effectively to corruption and inflated prices, which is a major problem. And there is fraud in the private medical schemes too, estimated at 19 billion rand a year. So when you have all this money going into the NHI fund, the opportunities for corruption will be larger. Then, in terms of the bureaucracy, we'll also have to have an NHI commission, which will oversee the NHI fund and to which it will report. There'll be an NHI benefits committee, which will set up expert subcommittees to decide on what treatment guidelines should be. But because doctors might find these treatment guidelines too inflexible on occasion, the white paper has another solution. We'll have another committee. So then there will be a clinical peer review committee to review the inflexible decisions of the NHI benefits committee. There'll be a massive data system established to track all health needs, for example, a whole number of other things too, but to track all health needs, to monitor them as they change, which will be a huge exercise in itself for 55 million South Africans. There'll also be a master patient index, which will have to be compiled and kept up to date all the time, and there'll be a master provider index. So I expect there will be a lot of officials needed to compile these various data systems. There'll also be health technology assessment officials, because when new medical technologies arise, the decision must be made as to whether the NHI will include these. So officials must decide whether it's really cost efficient to do it, given the need for sustainability of the NHI fund. So I think it could mean that new technologies, which are expensive, are unlikely to be allowed. Then there'll also be a national health products list compiled by officials, And if a particular product is not on that list, then it's not an authorized one for which payment can be made. We'll need many more inspectors for the Office of Health Standards Compliance. As I indicated, it managed to review 417 facilities in the public sector in 1 year, but there are many more public health facilities to be reviewed. There are something 25,000 to more than 70,000 potential private practices that might also need to be reviewed. So it's a huge task, and it has to be carried out for all facilities every 4 years. So how many inspectors will we need in the OHSC to make that possible? There'll be a district health management office in each district municipality. There'll be clinic committees for each of our approximately 3,200 clinics. And South Africa will have to pay for healthcare for all South Africans, plus the costs of this new bureaucracy. And that costs of that new bureaucracy seem to be left out of account by the white paper in trying to estimate what the NHI might cost. And against this background, I'd like to turn to, well, what are the alternatives to the NHI? Because the flawed system that we have now is not good for many South Africans. And the key point to make first is that we don't need NHI to achieve universal health coverage, to give all South Africans access to proper health care. We should rather use the private sector with all its strengths. We should build on what we have, what works well now, rather than seeking to put it to an end. And we should give the poor access to the benefits of the free market, which include competition and choice. We shouldn't leave the poor dependent on a public sector monopoly, which is what the NHI will be, with all its inherent inefficiency. We should also seek to expand the supply of health services rather than ration it. And what we will see under the NHI is rationing by time. Waiting times are likely vastly to expand, and many people will find it very difficult to obtain the health care they need at the time they need it, because the waiting periods are so long. And critically, we shouldn't raise expectations that at the end can't be met. We're promising 55 million South Africans quality, affordable health care that's free to them. If we don't deliver on that promise, there may be huge anger. We can see what has happened on the universities with the promise of free education for the poor. A number of radical students are now extremely angry at the government, the universities, the system. And we don't want to invite similar sense of having been let down. We also need to remove the adverse regulation I spoke about before. Government regulation has done much to push up the costs of private health care, so the regulation needs to be reformed. We should allow the private sector to train doctors and all other health professionals so as to increase supply and help cater for increased demand. We should allow private hospitals to employ doctors so as to help reduce their practice costs, a small but nevertheless significant saving. And we should also end the single exit price system, which bars discounts for bulk orders to the private sector, and which also, by the way, is helping to drive pharmaceutical companies out of the country, because the single exit price and the rather minimal price increases that have been allowed by the Department of Health over a number of years don't cater for mounting costs, especially as the rand shrinks. We should repeal the certificate of need provisions, which I think are like a sword of Damocles hanging over the head of all health practitioners, and should simply be scrapped. We should make it easier to establish private hospitals, including day hospitals, where a number of procedures can be carried out without people having to stay overnight, which can be a major saving. And other countries have many day hospitals. We have about 50, and we should have many more. And in particular, we should repeal the prescribed minimum benefits requirements, because they push up the costs of medical schemes for all South Africans. The great majority of people don't need the PMBs, but they're all paying for them. We should also restore risk rating within medical aid schemes. At the moment, we have open enrollment and community rating. So in other words, everybody pays the same, irrespective of their health status and what risk they pay to the scheme. Whereas if you allowed risk rating again, as we do with the insurance of motor cars, for example, then people would pay when they join the scheme according to the risk that they present. And the young and healthy would pay less, the old and sick would pay more, but there'd be a strong incentive for people to join when they're young and healthy, which is what you need in order to fund the overall costs of medical scheme membership. And we should also extend medical scheme membership. We currently have about 8.8 million people belonging to medical schemes, and most are paying more than they need to because of the compulsory PMBs and because of community rating. We should allow low-cost, limited benefit schemes which have risk rating so that people pay what is appropriate to their own risk profile and without the PMBs. And then what can we do to cater for remaining health needs? We should have mandatory cover for all, I'll come to that in a minute. And in terms of medical scheme membership, we should have mandatory cover for everybody who is in formal employment, including farm workers and domestic workers who are often really left out of account at the moment. And that would then bring the total number of medical scheme members up to 24.4 million. But you may say, how can people who are rather poorly paid possibly afford medical scheme membership? And I think the answer lies in the Council for Medical Schemes low-cost option, which it developed in 2015, which it planned to introduce this year, which it said would give people for premiums ranging from 180 per adult member per month to 240 per adult member per month, access to a whole number of specified benefits in the private sector, including 5 GP visits, medicines, optical and other care, though people would have to go to state hospitals if they needed that kind of treatment. But the mere fact that so many people would have many of their health needs met via the private sector would help to relieve the pressure on the public one. So at this basis, it would be affordable for all, especially if employers were asked to pay half. And what we should also have is mandatory health insurance cover, which will deal with co-payments and adverse changes in health status. So if somebody who was young and healthy when they joined is diagnosed with cancer, for example, and their medical scheme will not cover all the out-of-hospital expenses that they incur, they can have medical insurance that will cover a development of that kind. And again, we could ask employers to pay half of the insurance premiums, which would help to bring down costs. And because the pool would be so big, insurers would also be able to reduce premiums, because overall, the size of the pool would make it possible to cover the claims that are submitted. How do we help the rest? We've been talking about people who are in formal employment, but we have in South Africa very large numbers of people who are not employed and a large number of people who are young. More than half of South Africans are under the age of 25, and many of them, too, are either too young to qualify for formal employment or simply haven't been able to find it. So it's approximately 30 million people that we still need to cater for. And what we're proposing is this, that we should introduce state-funded health vouchers for the poor, that we should use some of the state's revenue, and I'll give some draft figures in a moment, in order to give people health vouchers, so which they can use only for health-related expenses, but which give them a power to purchase. And what would they be able to purchase? They'd be able to buy medical scheme membership with limited cover, with risk rating, without PMBs. And they'd also be able to buy medical insurance. And, sorry, I'm getting ahead of myself. The premium for this kind of medical scheme coverage could be 180 per person per month, the same as what the Council for Medical Schemes indicated with its low-cost option last year. And I think that's perfectly realistic given the size of the pool and the fact that many of the people to be covered would be children, for whom premiums are generally lower. Each would also have to take out health insurance at, say, 50 Rand per person per month. At the moment, you can get such insurance for about 100 Rand a month. Again, with the size of the pool, it's possible that insurers could reduce the premium to this kind of level and still be confident of covering liabilities. So the total cost could be $230 per person per month, or $2,760 per annum. And these are, of course, are estimates, but they give you some idea of what might be feasible. And if you look at Discovery, which is our largest private sector healthcare scheme, it has a particular option, the Discovery Key Care Plus, for the poorest, which charges $290 per person per month and offers many benefits, including the PMVs, but has a small member pool. So with a much bigger member pool, you would think you could bring down the costs. So if we accept my MIG figures, we have a requirement of $30 million at $2,760 per person per annum, which would come to $82.8 billion. How could we cover that? Well, the DA says we could fund it via the tax credits, which SARS currently provides to those who have medical scheme membership, which cost about 16 billion rand, and part of current provincial spending, which comes to 160 billion rand. The South African Private Practitioners Forum has spoken of a 20% savings on medical scheme premiums from compulsory membership for all employees, and that sum would amount to 27 billion. And as I understand it, they recommend that instead of reducing premiums for existing members who are already paying higher amounts, we should retain that money, so that 27 billion also becomes available to help fund healthcare for the poorest. So if we take that, then we have 16 billion plus 27 billion, which is 43, and a shortfall of 39.8 billion. And that, of course, is much more feasible to attain. And it could be covered through efficiency savings in public healthcare and elsewhere in the public service. Remembering again Kenneth Brown, the Chief Procurement Officer in the National Treasury, saying that 40% of the government's 600 billion procurement budget is being affected by fraud and inflated prices, is not being properly used, in short. And if we could reduce that, then we have more money available. We also should improve efficiency in public hospitals and clinics through private sector partnerships. The government would set the parameters, but private sector providers would compete to run those hospitals and clinics in an efficient and cost-effective way. And all medical schemes should also include health savings accounts, so unspent monies can be carried forward and used as people ultimately want, to discourage overuse, and also give people a sense of greater choice about how they spend their healthcare vouchers. And critically, it's important that we change the terms of the debate. What we have now is really a sort of false dichotomy. We either go on with what we have now, or we have the NHI. And the ANC is setting the terms of the debate, and in doing so, it is very much demonizing the private healthcare sector and making it seem that it's the private healthcare sector which is responsible for all our ills, when this is not so. When the private healthcare sector is a strength that we need to preserve and use. I believe that the key aim behind the NHI proposal is to advance the national democratic revolution, in terms of which South Africa is to be taken from a predominantly free market economy to socialism and ultimately to communism, and that you can make steps towards that goal by putting an end to private provision in healthcare and by establishing the pooling principle that private sector monies, public sector monies must all be put together into one pool to cover everybody. And this could be applied in future, perhaps in the pension sphere. The vital issue, of course, is the economy, which so many of us seem to overlook. We have growth estimated at 0.4% of GDP in 2016, and it may be less than that. We have stagflation, this very low rate of growth, and yet 6% inflation. We have close on 40% joblessness on the expanded definition, which takes account of people too discouraged to keep looking for jobs. We have 67% unemployment among young people aged 15 to 24 on that expanded definition. And in these straitened economic circumstances, obviously it's more difficult for South Africa to afford universal health care. So let us grow the economy, let us expand the cake, and then we can use it more effectively to provide health care. The key needs are therefore to expand jobs, for which we need investment and growth, to increase the supply of health services rather than reduce it, to encourage competition, because it's competition that helps to bring down prices and also helps to improve efficiency, which is another key goal. And critically, we should empower people rather than the state. If people have healthcare vouchers which enable them to buy their own medical scheme coverage and health insurance, they have power over their healthcare spending. They don't have to rely on what the state provides, which in most circumstances will be very little and very late. Thank you.
Thank you very much, Anthea. Any questions for Anthea? Start with that.
Did you come here to cheer us up?
I came here to give you insight into a different way of doing things.
Okay. There was one really shocking statistic you put up there. Am I correct in saying that baby deaths in this country are more than murder and road deaths put together?
That was the conclusions reached by the council, the South African Medical Health Council. They looked at infant deaths, in other words, those who died within 28 days of birth or stillbirths, and came to this rather shocking figure, which was encountered over the 2 years from 2012 to 2013.
And the final question is, if the tripartite alliance falls apart, do you think this communist project will fall apart as well?
I think that we stand perhaps on the cusp of a major political realignment, which I think gives some reason for hope. We've already heard Julius Malema, though he denies it now, saying that the EFF in 2019, in its role as kingmaker, if the ANC gets less than 50%, would be able to join with the ANC, make sure that it's called something different, and then the EFF, which strongly endorses the NDR there, they don't say so in so many terms, and the ANC would push ahead with it. But there are very many people in the ANC, I think, who are worried about the damage to the economy, who recognize that Marxism is a failed system, who don't want us to end up where the NDR at the moment is taking us. And it's possible that part of the political realignment would see a splitting of the ANC with a more moderate element within it, perhaps joining with the DA so that we have a bigger group there that can help us to preserve the free market system.
Questions? Gentlemen?
Thanks, Anthea. Could we know what communications there have been with government and how that has gone on your project?
Well, we've simply made submissions. We made a submission on the NHI white paper at the end of May this year, and we've just now, on Friday, made a submission to the Davis Tax Committee, which is looking at the funding of the NHI. Beyond that, we haven't got very far with talking to government directly about the NHI, but we have been in communication with some senior ANC people about the need for a shift in direction, about the need to preserve the private sector rather than take us into this dead end.
Anthea, do you know when the government is going to bring this in?
Well, you know, as they see it in the white paper, it's a process. So the 2025 would be when the NHI becomes fully operative. But all the way towards there would be taking steps towards it. And then from 2025, fully operative.
Catherine, do you think there's a sense in government now that some people are beginning to realize you can't afford it? I mean, I think the shortfall on the white paper, if you don't grow at 3.5%, is some ridiculous figure of billions. Do you think the ANC or certain people realize that it's a good idea to stick and vague and impossible financially?
Yeah, I think again there must be a growing awareness of that, because we know that the finance minister, for one, who has certain problems of his own, is trying very hard to ward off a ratings downgrade. And as I said, the ratings agencies have highlighted the NHI as one of the liabilities potentially for the government that they're worried about, because we already have such a high level of public debt, which has grown exponentially. It's not so much that the debt itself is so very high, but the progression, the doubling in 8 years is the worry. And the fact that we're already paying so much on interest. And of course, if we get downgraded, then borrowing costs go up for everybody. and economic growth is no doubt further affected. So yes, those who are in support of the finance minister must also be worrying about the costs of the NHI and whether it could help trigger a ratings downgrade.
Slightly related to that. So, and then just with regards to the health vouchers, where would that come from? So the funding for those health vouchers, where would it actually come from?
We're saying, first of all, 16 billion by scrapping the tax credit. Secondly, the 27 billion that the SAPPF talks about, that if you can reduce premiums on medical scheme membership but not give existing members the benefit of that, keep it back, a piggy bank, that gives you another 27 billion rand. And then the shortfall of some 39 billion rand can be met through efficiency savings in the public sector and elsewhere. And we can attain the efficiency savings in the public sector by bringing in the private sector to help run private hospitals and clinics and make sure that the revenue which is available in those facilities is being properly used to its full benefit.
Yeah, I just wanted to say thanks for the well thought out, what's the alternatives and the options, because it's always easy to criticize but not come up with what is possible. The way I look at it though, it's like the NHI as it is proposed now is probably far to the left, and what I've heard is a bit also far to the right, and somewhere there is a middle, road. And I think we can all hope that ultimately we can talk such that we get to somewhere in the middle.
That's your view. I think what I've sketched will be the most efficient and effective way of making sure that we extend health coverage to South Africans.
Hi, thanks. Is there anywhere globally where the private sector, or the free market, has effectively been in charge of the health of an entire nation and successfully managed to ensure that the poor do have access to quality health care?
Well, we know that the private sector hospitals are the ones that are run the best at the moment, that they have the best outcomes, that they don't have the problems of cleanliness, of lack of infection control, and so on, that are plaguing the healthcare sector, as well as the non-payment of suppliers, all of which is contributing to inefficient services within the public health sector. And I've sketched some of the reasons why I think those problems have arisen. So we also know that public-private sector partnerships have been used effectively in other spheres. I haven't looked specifically to see whether they've been used in the health sector. But in a range of functions throughout many countries in Africa, the private sector has been brought in to make up for the inefficiencies in public sector and make sure that there's a greater level of service at a lower cost to more people. So I think it's a model that we should certainly explore.
So there's no example globally that you
South Korea is one of them. South Korea. To what extent do you know if before 1994, my recollection is that almost all hospitals where everyone got treatment from public facilities. This privatization of hospitals came in after that.
No, I think there always
the
has
growth
been.
thereof.
Yeah, I think there always has been a public sector and a private sector in the country.
But not at the
And
same
I think
magnitude.
that there always was some usage of the private sector, not just by the middle class, but by other people as well, making out-of-pocket payments. And so yes, I think it's a long-established thing that we have both. And we should use the strengths of the private sector to help the public sector.
In terms of PNBs, as I understand it, those benefits were put into medical schemes to protect people. If you have chronic disease like diabetes, they would run out of money for say, insulin in September and then get much sicker and land up in hospital in January with a stroke or blindness or some complication of diabetes. If you take away PNBs, what protection does the consumer have? And
Health
medical aids
insurance.
aren't exactly always acting in the best interest of their members.
If everybody has health insurance, they have health insurance for hospital plans, they have health insurance against major diseases such as the development of cancer, then those funds will be available to pay for things that the medical scheme doesn't cover. And that's the way to go, because you can get quite cheap insurance, because particularly if you have a very big pool, only a limited number of people will need to claim in any 1 year. And it's the pool that will make available the funds for those who particularly need it.
That's great. So if you're a poor person in the township who's overweight and eating crap, they're not going to give you insurance cheaply because you're high risk and you already have diabetes, high blood pressure, overweight, stress, arthritis. So
Well, I'm not sure that that's true, because we already have insurance, life insurance for people who have HIV/AIDS. We have life insurance for people who have diabetes. And from what I see, this is not unaffordable for the great majority. And again, if you're talking about a much bigger pool, you can bring the premiums down further. And I think we must also think that we should rely on the entrepreneurship and the innovation and the ingenuity of the private sector in devising solutions to problems, rather than leaving out of the equation.
Sorry, the last time I went to a presentation by the minister, it seemed to me that he was very good at articulating the problems of our healthcare sector. You know, people sort of running out of benefits and all this, that sort of, which we all suffer. So I think, you know, the interest is there to try and not have a system that people by half year end simply cannot afford. He was going to go to the National Treasury to try and show them the plans that he had, which, as you say, are more really a redistribution model. Is there a way that you have access to the minister himself or to National Treasury to present this? And would you be able to say the alternative that you present is benchmarked against some kind of international model, or then to prove its viability? I'm really going towards, is there a chance of actually convincing government by showing the practical application of this model? Because I think all of us just tend to talk. You know, the minister will come and he is a certain perhaps political or ideological slant. I'm a member of the Free Market Foundation myself, so I understand our slant. But what we need to do is to make people who have the purse, call it National Treasury, understand what we mean and how much this would be better. Do you think that's possible? Because he's going to go straight to National Treasury. I think you should go to National Treasury and say to them, guys, this is the alternative, it's better, cheaper, or whatever, but be able to say, there is a model, whoever. We've benchmarked it. Because those people, I think, understand numbers, they will appreciate that.
Yeah, we have an opportunity via the Davis Tax Committee. We've already made a written submission. We'll make an oral submission early in November. And it will be an opportunity to interact with people with a strong awareness of the limitations of the tax system. And when you talk about the out-of-pocket payments, yes, part of the reason that people run out of benefits so soon is because medical aids have to cover the PMBs, which pushes up the cost of premiums for everyone, together with the community rating. So in order not to make it so unaffordable that nobody can manage it, they then have a certain limits on the benefits that are provided, greater limits than they would otherwise need to have, which does push more people into making out-of-pocket payments. But on that, I think it's also probably relevant to look at South Africa in international context, because here the out-of-pocket payments make up about 7% of overall health expenditure, whereas in the BRIC countries it's very much higher. See if I can remember the statistics. In Brazil, it's 30% out-of-pocket payments as a proportion of total healthcare expenditure. In Russia, it's 48%. China, it's 58%. And in India, I'm guessing, I think it's about 34%. So in other words, though there is a concern about out-of-pocket payments, in South Africa we are doing less badly than other countries on that. And in fact, compared to many other African states, we also have a lower proportion going to out-of-pocket payments. But beyond that, we will also say that through medical scheme membership and health insurance, people should not be left without cover.
So if I can just add to that, and I understand your point about insurance and the ability to pool the benefits of our lives. I agree with you. But one of the other things, for example, I noticed, the minister had a lot of statistics which would almost be saying the opposite of what you're saying. And I think part of the problem here is people come up with statistics. We all are not statisticians. We really have no idea what statistics are sort of measured on what basis and all that. But those statistics seem to say that South Africa's medical system is much more, say, aligned with what goes on in the US than what goes on in Europe, where they also have a, shall we say, a slant towards a redistributive type of health system. And the countries that you measured, he seemed to be saying, from what I can remember, that they were kind of better than we are. And I'm just saying, these debates over numbers, getting together with him or with Treasury especially, I think would quickly dissipate some of these, which might well be myths, and then we can maybe get onto a much more grounded system that's going to help more people in South Africa.
Certainly, I would like to do that, to make such presentations. But I think also that when we look at comparisons with the US or the UK or so, these are much wealthier countries with a much lower level of unemployment, with more capacity to fund not the NHI, but something similar to it, and yet they're running out of money. They're having great difficulty. There are long waiting periods and so on. So I must say I was rather struck by the lack of statistics in the white paper, other than some of the ones that I've mentioned. But certainly, we should build as powerful a case as possible and present it to those in authority.
And that relates to the earlier point that Ayanda had raised in terms of influencing, say, the Minister of Health. We have to come to terms with the fact that when you have policy initiatives that are ideologically driven, the architects of those policies are intransigent people. It is difficult to influence them. You can throw whatever empirical evidence at them. It will not make any difference at all. And this might be one of the basic problems. But the point is about the exercise of say, extending the research to other people, say, around the Department of Health, for example, is that there are a few open-minded individuals who are looking for empirical evidence out there, well-argued, well-rationalized sort of presentations and so on. And these are the people that I think will be receptive to your presentation. Now, when you do that, the ideologues become isolated because now, they are confronted, by the people, their own colleagues, who question them on the basis of the evidence that's been made available to them. So, whilst I say it would not be, you need to be encouraged to take this forward to the appropriate people. But I think you also have to come to terms with the fact that there are really these ideologues that will never change, irrespective of the consequences of policies that they might be advocating. That's the reality.
I hear what you're saying, and I think that is the great problem with ideologies. They simply disregard practical constraints on what they seek to achieve. We had this in South Africa for a long time with the apartheid ideology, and now we have a different ideology that's in place. And it is hard to persuade an ideologist of a practical alternative. So certainly I take your point. If one can influence people around the minister, that would help. I think what would be great if we could also get a real public debate on alternatives to the NHI. And the media has a crucial role to play in this. Very much what we've seen in the media has been the view that it's the NHI or a failed system or failing system. So it's very important that this kind of different perspective should get into the media, and particularly newspapers that reach the vast majority of people. Because if there's public pressure for a different system, the politicians are again more likely to yield to that.
Yeah, my question is very similar. When the Green Paper came out with NHI, there were all sorts of submissions. Then 4 years later, the imminent White Paper comes out, and it's hard to change. It's just a bit longer and vague. Do you think the many submissions will be listened to this time? Because they certainly went...
Well, this time we're on the brink of a ratings downgrade. And the economy is clearly really struggling. And there are a number of people who want to avoid that outcome. And I think we're closer to a political realignment, as I said before, than we were before. So it may be that you can narrow the support for the ideologues and get to the more pragmatic solution.
Are you happy to go on taking questions?
Oh, yes.
Your voice is holding out.
My voice is just holding out here.
And I think I'm echoing some sentiments that have already been mentioned in terms of far left, far right, and the importance of meeting a middle ground. Someone mentioned the South Korea model, but that's a universal health coverage system that is funded through the government. Government sets all the rules, etc., but the public sector builds and runs the infrastructure. So there is some sort of middle ground in that example. That's why I was struggling to find an example where the private sector, as per the alternative you've given us, has so much influence and power over what ultimately is a problem for the poor, not the people with access to healthcare. If you give the private sector so much power over that, ultimately they will not. I mean, currently the private sector, in terms of the issues we get with medical aid every day, prove that. And if you look at insurance for people who already have certain ailments such as HIV, I think the private sector was forced into insuring those people before they did it, and then everyone else latched on. So I'm just wary of any solution that leaves everything in the hands of the private sector to run everything, and then and doesn't help in improving the efficiencies of the public sector. So the public government hospitals are there for the poor. So I'd rather see a solution that takes private sector knowledge, efficiencies, expertise in improving the public sector, and not creating a monster that effectively kills the public sector.
That is what I was saying, that we should have public-private partnerships, that the Department of Health sets parameters, that private providers compete on price, efficiency, etc., to be able to run hospitals within those parameters. And if one private provider doesn't do a good enough job, it can be fired, and you can have a new competition for somebody who can do it better. And what we're talking about in this system is not leaving the poor dependent solely on the public service. You're saying that in this way, the poor will also be able to afford private sector costs. And where you have a number of private providers competing for the custom of people who have health vouchers, belong to medical schemes, have hospital insurance, then that competition in itself will encourage them to be as efficient and cost effective as possible so that they can draw more people to themselves. And that's the strength of the free market system.
One last one. I think it was your institute, correct me if I'm wrong, that suggested vouchers for the poor to go to school, so they could choose between private schools and dysfunctional government schools. That hasn't really been welcomed politically. Do you think this might be, this is the same kind of idea?
Yes, it is the same sort of idea. You're quite right that we did a while ago put out a quite detailed article on the possibility of education vouchers, that again, you take a large part of the government's existing budget and you split it up among parents in the country, and every parent gets an education voucher for their child. And on that basis, parents then have a greater choice than they have now. And some of the really dysfunctional schools in the public sector could be sold off to a private sector provider or an NGO that would then be competing for the custom of parents with these education vouchers. And yes, there is a lot of resistance. I think SAT2 is very opposed because apart from anybody else, it would be a system that would erode the power of a trade union, which at the moment is helping to keep the education system ineffective, is not helping the poor to get ahead. So one would run into political opposition, no doubt. But one's hope is the political realignment, the economic realities will encourage people to look more carefully and with more willingness at pragmatic private sector options.
If not, I have a question from Dr. Ruth Rabakowitz from the YouTube channel. This is going out live to the Free Market Foundation YouTube channel. And she asks, how does NHI compare to Obamacare?
Oh.
That's another presentation myself,
That's
probably.
another presentation, and I don't know enough about her government. But I have read something recently saying that it's not working very well, but I wouldn't like to say more than that.
Anything else from the audience? Otherwise, I will ask questions.
Just lastly, what do we tell the public? They usually ask you, when is NHI going to happen? Is it going to happen at all?
Well, I think we need to say, this is the government's proposal. What it will mean is that there will be fewer doctors and health professionals available, perhaps many fewer health facilities that qualify for participation. Services might be free, but waiting times will be very long. And that, therefore, this is not a system that the poor should be looking forward with eagerness, despite the promises that have been made around it. And instead, we need the pragmatic alternative that really will empower the poor to buy the health services they require from either the public service with its increased efficiency or private providers.
Okay, well, thank you very much, Anthea, for a truly frightening presentation, as someone said. There's some very good ideas in there and options that the non-ideologues can take on your views. So thank you very much for everyone who's come along today. There is still some refreshments at the back. I think Anthea will be here for a little while. Questions. Our next event is a Free Market Foundation evening event on